Dr. Arianna Means is an assistant professor with the University of Washington, and she's going to be speaking about some work that she's led on adapting the consolidated framework for implementation research in low and middle income countries, and specifically sharing some lessons learned and a case study from deworming programs in India, Benin, and Malawi. A little bit about Dr. Means. So she is co-director of implementation science in the Global Center for Integrated Health of Women, Adolescents, and Children at the University of Washington. She's also Associate Director of the Center for AIDS Research, the CFIR Implementation Science Core. In collaboration with partners in low and middle income countries, her work has mostly focused on improving the delivery of evidence-based interventions that affect child survival, growth, and well-being. She teaches the online Fundamentals of Implementation Science course for master's student, and she also directs the UW Summer Implementation Science Institute, which I've heard many, many wonderful things about. So she has been involved in training over 1,000 trainees, health workers, and policymakers around the world each year. So I'm really, really happy to have you join us and welcome. And if everyone's okay, we're going to be recording this session. Okay, thank you.
Thank you so much for this introduction. It's so nice to be here. It is so fun for me to go to other institutions and meet implementation scientists there. So just thank you for extending the invitation. I'm glad I finally made it. I'm also humbled by the people I see in this room. I see many familiar names. And I am just excited to be in a space with all of you today. Yeah, thank you for the introduction, Rachel. She mentioned, my name is Ariana. I use she, her pronouns. I'm based at the University of Washington in beautiful Seattle. It's actually a sunny, gorgeous day here today, which we don't always get at this time of year, on the traditional land of the Duwamish people. And I'll be talking about my experiences applying the CFIR in low and middle income countries, particularly with a focus on India, Benin, and Malawi here. But I know there's a lot of you in this room who have a lot of experience applying the CFIR too, I can see. And so I hope that we can have kind of an open and rich discussion at the end about your experiences and lessons you've learned and kind of pathways forward for the field in general. So I'll try to tee us up for that. So what we'll talk about for this time together, I was going to do a quick refresher on why we care about frameworks. And I think some of you in this space probably have different experience and exposure to frameworks. So again, I invite you to share your knowledge also, either in the chat or at the end, about why we care about frameworks. I'll talk a little bit to set the stage, kind of an overview of the CFIR, thinking about from its formation to where it is now. I'll talk a little bit about a systematic review we did about thinking about the relevancy of CFIR across contexts. And then I'll give this example of how we've applied the CFIR across this multi-country study where we kind of required standardized use of how we deployed the CFIR in order to have pooled findings, but the settings were very, very different. And then hopefully we can have a rich discussion. I talk about frameworks a lot with colleagues and trainees, and sometimes I can see kind of like panic wash over people's face when we start to talk about frameworks because just people are like, I just want to do the work. This is a lot of jargon, like, okay, tell me what I need to do and like, let's get it over with, basically. But frameworks are not supposed to make you have like this bottom right frustrated face. I use this with my kids sometimes. They're supposed to root us in this kind of shared common language. They're supposed to help us add order sometimes and root our work in theory. So my goal for this presentation is to help kind of think about how we make these frameworks more accessible across contexts. If at any time I am drifting away from this objective, do feel free to stick in the chat or interject and be like, too much jargon, back it up. I'm very open to that. So, as many of you know, we do care about frameworks and implementation science, and we do use them a lot. And there's a lot of reasons why. Most simply, because evidence-based interventions, evidence-based practices, EBIs, this includes things like PrEP or vaccines or deworming drugs, as I'll talk about later, for example. And the strategies that we use to improve the delivery of them, things like patient navigation, provider incentives, audit and feedback, community sensitization, these are not one size fits all. When I talk about community sensitization in my work in Seattle, I'll be talking about it very differently in my work in Malawi or India. Context really, really matters. And you all know that. That's why you're interested in implementation science. It matters for shaping the challenges we face. It matters for how we select strategies to overcome those challenges. It matters for how we communicate about them and how we think about scale up. And often in any setting, we're facing multi-level challenges, multi-level barriers to implementation. And this often requires, not in every situation, but it often requires multi-level problem solving. And this is why, in theory is so helpful to implementation science because it provides this very structured, standardized approach to holistically thinking about these very complex delivery challenges. And so, just a note before I go on, there are really important conceptual and pragmatic differences between theories, models, and frameworks. Sometimes we call them TMFs. I'm just going to say frameworks for short today, and I'm not going to dive into those distinctions, but if anyone wants to later, we certainly can. Okay, so just kind of continuing with setting the stage of why frameworks are so useful and important. They can help us frame our study questions and anchor those questions in the background literature. So, meaning they can help research teams draw from theory to develop those research questions and then link those questions to similar questions that have been asked before and compare findings. They can help us select implementation strategies, meaning, as you know, the strategies that we're using to try to improve delivery of evidence-based interventions, which is a central premise of implementation science. They can help us guide implementation across contexts by helping us think about these determinants or facilitators and barriers to implementation and how they vary by setting and how they vary within setting. And I'll talk about that in a little bit. They can help us develop research tools like survey items, like question guides, like latent variables, um, by helping us think about how we draw from these constructs and then develop and validate measures to actually understand them and interrogate them. This also helps with research translation kind of across settings. And then finally, frameworks can help us guide our analysis in a lot of different ways. And once we've analyzed our results, it can help us illustrate and contextualize our findings using a framework as a guide. So I'll give a few examples of all of these things later when I'm talking about the specific case study. So I think when we're talking about use of frameworks across different settings, I think one of the most useful aspects of that is that it provides this common language for talking about factors that influence implementation when we're talking about determinants frameworks in particular. So multiple people on this call, for example, might be doing work around HPV vaccines among adolescents. And some of us might be working on it in Seattle or New York or South Africa or anywhere in between. And if we use a common framework, we have this common language to talk about the unique factors that are influencing effective vaccine coverage, those multi-level challenges that influence things like vaccine supply, behavioral phenomena that influence vaccine uptake, and so forth, so on from setting to setting. So this common language is really nice because it helps us think about potential solutions and how those solutions are uniquely fit for purpose or not from setting to setting. So that's a little bit about setting the stage for frameworks. Um, and now I'm going to dive into the CFIR in particular. And I am keeping an eye on the chat just in case anything comes up. Um, so I know for a fact many of you on this call have used the CFIR before, or perhaps are considering using it. But I'm still just going to kind of set the stage just in case anyone's less familiar with the CFIR. It's a very common framework used in implementation science, and this is in part because the CFIR was built on pre-existing implementation theories in order to offer this very comprehensive theoretical framework. For this reason, it's often called a meta-theoretical framework. And the purpose is really to help us understand across different contexts whether and why interventions do or do not work. And here you can see the seminal paper by Laura Damschroeder and colleagues. It's very well known, very highly cited, and a lot of people who come to implementation science come knowing about the CFIR already. And so the CFIR is got 5 main multi-level domains, and within these domains, there are specific constructs that are used to kind of characterize what we call implementation determinants, sometimes put simply as facilitators and barriers, often extending beyond that. And these domains include things like characteristics of the innovation, the inner setting of implementation, the outer setting of implementation, individuals involved, and the process. And so, just very briefly, this characteristics of innovations domain, this gets at the idea that um, the intervention might influence implementation and be acting as a facilitator and barrier to successful delivery. So things like here we can ask questions about the complexity of the intervention and how complexity does or doesn't influence successful implementation. That's my favorite construct from that domain. And then we have the inner and outer settings, which describes the context. This is really important for what I'm going to be talking about next. These vary so much depending upon the intervention. When I think about the inner and outer setting of all the work I do with prep navigators in Mississippi, with syringe service programs in Seattle, with deworming programs in Kenya and Malawi, the inner and outer settings so different. Within Malawi, across different districts, the inner setting is so different. So these are really important features of implementation that have a really big impact on the determinants that are at play in any setting. So, for example, when you're talking about inner setting, often we talk about at something like a health facility or a school or a community. We could talk about things like resource availability. Whereas in that outer setting, we might be talking about higher order issues like financing. And then with the individuals involved, this is where we're talking about things like agents of change, people of power and influence. And I love this domain because it helps us think through the different roles and the types of influence that people have. So, for example, there's some work I do with the University of Gondar in Ethiopia that engages faith leaders from the Orthodox Church and pairs them with community health workers to deliver newborn care home to home. And when we use the CFIR, the individuals involved domain, we can really parse out who's technically leading implementation, but who are the real opinion leaders who are affecting kind of recipient decisions to participate. And what's the relationship between these different leaders and these different decision makers that can actually facilitate or hinder the acceptability and the reach of newborn care. So there's a lot to dig into with the individuals involved. And then lastly, the implementation process. This really describes this very active progression towards targeted outcomes. It really highlights that implementation is not like pre-post. There's so much in between. It's really a cascade of activities and the multiple rounds of adaptation that inherently happen in between. So each of these domains, as many of you know, has a menu of CFIR constructs within them. And here you can see constructs specifically for the first iteration of the CFIR, what's now called CFIR 1.0, still widely used. I still use it in many of my projects that started with CFIR 1.0, and we haven't yet transitioned to CFIR 2.0, which you can see here. So in 2022, Dan Schroeder and colleagues released a CFIR update. And they made this update after reviewing literature and conducting interviews with authors who had used the CFIR. And you can see many of the constructs are the same, but many are pretty different. And they made these updates in part because they received a lot of feedback that compelled them to simplify the CFIR. I think in their survey, over half, nearly 60% of the respondents of the authors said that the CFIR was more complicated than necessary. So I think this was a really nice step to really focus on simplification. This new version has 48 constructs, 19 subconstructs across these five, basically the same domains. And I think these are exciting updates, and I'll talk more about that in a minute, particularly for those who work in non-Western settings or in lower resource settings. And I think we'll dig into that in a second. And so kind of setting the stage with why do we care about frameworks and what is the CFIR and what is the trajectory of the CFIR been over time? I just want to pause for a moment and invite you to put in the chat, or if you want to raise your hand, to kind of reflect on this question. What conditions or circumstances might influence the relevance of the CFIR, which you just saw, in a low and middle income country? I could also caveat this to say in a lower resource setting or a non-Western setting. I'm sure everyone has we could spend a whole session, a whole class talking about this, but I'd love people just pop in a few ideas. Healthcare system structure? Yes, absolutely. What other thoughts do people have? Yeah, investigator familiarity with constructs. Resources, time available to use the CFIR constructs with fidelity. Yes, these are all great, great examples. I think we often think about any health system, yeah, policy, political context, infrastructure for access, technology, computers, absolutely. Yeah. So operationalizing the CFIR will look different setting to setting. At the same time, across different settings, we see different resources available, as you've all pointed out. We also see different types of predominance and implementation norms. In some settings, this isn't necessarily limited to higher resource or lower resource. We see more individualistic societies. We see more collectivist societies. We see nations where there's multiple health systems, nations where there's national health systems. We see settings that are largely funder driven. We see settings where colonialism and neocolonialism and racism have a huge effect on the way that healthcare is delivered. And so across all these settings, that means we often see different determinants at play. And the relevance of something like a framework might be weaker in settings where that framework wasn't necessarily intended to be operationalized. So all that to say, when we think about something like a framework that was developed in a Western setting, we're compelled to think really critically about the relevance of that construct, of that framework, in a setting that's really different culturally, systematically, politically, and socially. Um, in general, anytime we put a label that something is universal or standardized, quote unquote, we can sometimes perpetuate the idea that those methods and tools from a high income setting here are dominant or prevailing or have to be blindly used in order to ensure that research is rigorous. And that doesn't necessarily mean that we need to throw frameworks out the door, but it does mean that we need to come with this level of thoughtfulness and introspection. And that's what I'm going to talk a little bit more now. Before I do, I just wanted to highlight this beautiful publication that came out relatively recently from colleagues that I really admire at the University of Zambia who reflected on this very issue. So I just wanted to share their direct words on the topic, which is they said the rich plurality and complexity of our context is lost by the push to make sure our findings fit neatly into existing TMFs, theories, models, and frameworks, whose origins are from clinical settings and systems in the global north. Our use of TMFs is value-laden and influenced by varied factors such as power relations and research partnerships with institutions in high-income settings, limited resources that inhibited us from delving deeper into implementation science questions, poor basic service delivery infrastructure, underdeveloped health system building blocks that are often taken for granted in TMFs from the global north, and short-term timelines and changing priorities of funders. Implementation scientists must be epistemically open, drawing from different theories and methodologies from across multiple disciplines, even those that seem incompatible. Theories then become heuristic and discursive weapons to understand the social world in which implementation is occurring. So I just love this. I recommend reading the whole paper. It's so good. And I think this really kind of highlights the idea that frameworks are so valuable. They're so valuable and they're really important in implementation science. And yet we must always not necessarily take them for granted and continue to think about where they are exhibiting strengths and where there are opportunities for innovation. So that kind of leads me to thanks. This kind of leads me to what I'm thinking, what I'm going to be presenting next, which is a systematic review that we did on this very topic. And I want to highlight this timeline of when the CFIR first kind of launched. It was published in 2009, and when we did our review, which was 2017, 2018. And a review on the CFIR was done just before that by Kirk and colleagues, and They did a review of the CFIR and tried to understand how it was being used. They found at that time 26 studies that used the CFIR, and only two of those were conducted in a low and middle income country. We did our review a few years later because we understood that, part of the underuse of the CFIR and LMICs might be that, again, it was developed in a Western setting, so it has to kind of naturally disseminate to other parts of the world, but also was there kind of a systematic difference between higher income settings and low and middle income countries that might act as a barrier or limit the utility or the relevance of the CFIR in other settings. And that was kind of the driving rationale of our systematic review. But I want to highlight this timeline because this is when we did our review, and this is how we see articles citing or mentioning the CFIR in their title or abstract since then. There's been a huge increase in use of the CFIR. People got very busy during the lockdown, it seems, publishing. And so there would be a lot more studies to include in a review now, presumably. So if anybody here is itching to do a systematic review, this would be a good one to update. So briefly, the objectives of the systematic review were to um, assess the use of CFIR in implementation research in low and middle income countries, and to propose potential modifications to the CFIR to improve its relevance. And so we did a systematic search that again ended in 2018 to look at literature that cited the original CFIR and took place within an LMIC. We had two independent reviewers looking at all titles and abstracts and then full text. At that time, we found 27 studies that were taking place across 20 LMICs. Most of them applied the CFIR post-implementation. This was concurrent with the Kirk article at the time. I think there's been huge progress in this front. I guess kind of the main message from that is that time people weren't necessarily baking the CFIR into their study design, but were more using it for interpretation at post-data collection. I think now if we redid this, you would see a lot of people using it for kind of study design, strategy selection, tool development, et cetera. Most applications were to guide data analysis or contextualize the study findings. And at that time, only two of them linked it to study outcomes. So in other words, looking at the relationship between specific CFIR constructs and specific implementation outcomes. But what I think is most interesting to dive into here is thinking about which constructs were more or least relevant in the settings where these studies took place. So here you can see the frequency in which different constructs were leveraged across the studies in our review. And keep in mind, this was CFIR 1.0. And so what's most interesting perhaps here is to compare the frequency in our review to the Kirk review, which was a few years later. And you can see that here. So you can see that studies that took place in LMICs were more likely to draw, I don't know if you can see my cursor, more likely to draw from constructs in the inner setting domain, far less likely to draw from constructs in the individual's involved domain. And we conducted surveys with authors of included papers, similar to what they did to update CFIR 2.0. And we learned a little bit about why this occurred. And responses we received were largely because in these non-Western settings, implementation, adoption, and scale up, all of these were really viewed as being driven by more collectivist norms, as opposed to these very individualistic realities and workplace dynamics. And so the inner setting does a better job of reflecting teamwork and group dynamics, was some of the feedback that we received. We also asked authors which constructs were most and least compatible with their work in an LMIC. And so in the green, you can see where participants kind of unanimously noted that a construct was compatible, and red was where 5 or more participants noted that a construct was incompatible. These were authors again. So the constructs of culture and engaging were deemed kind of universally compatible. And in qualitative follow-up, we heard that authors, these constructs were so important, but they really thought they should be more nuanced. Culture is such a broad construct. Whose culture? What about culture? Same with engaging, like really an important construct that people really desired more depth to when they thought about determinants. Engaging people at what level? What people? Why would they need to be engaged? So it was clear that in these non-Western settings, the researchers really sought more information about community engagement and how community engagement affected implementation processes. So, kind of the main messages from this review were that implementation research in LMICs often requires study of health systems. And you all brought that up as one of the main barriers of why you thought CFIR might not be relevant in every setting. Systems are very complex. And at multiple operational and administrative levels, the CFIR doesn't necessarily fit at that time with the way people really sought to conceptualize the inner and outer setting. Also, many LMICs have hierarchical structures and much more collectivist structures that aren't necessarily compatible with Western conceptualizations of the role of the individual and the way that an individual's can affect change or the way that their readiness might influence implementation at an individual level. And so, due to these resource constraints, there's a big focus on the need to look at sustainability of interventions, as well as resource source and flow, and then not written on the slide, other things related to team dynamics. At the same time, we received a lot of feedback. Do not make this any more complex than it already is. And then just to add, there's this, I think, another challenge that we didn't write in our paper, but we observed a lot in our work around this time too, that when we talk about determinants, when we're talking about barriers and facilitators, these don't just exist. Barriers and facilitators are really produced and consistently reproduced by decisions and by actions. Maybe not intentionally, but as organizational policies and practices or the outcomes of organizational policies and practices. So when we talk about a robust framework and extending frameworks to take what we know about barriers and facilitators and then use that to guide intervention design and analysis, we have to really be sure that our programs are actually well suited to overcome those barriers and that we're not consistently replicating those barriers and facilitators simply because we're not going to higher order issues that are at play. So for those of you who like causal diagramming, this kind of gets at the idea that there's often causal relationships between determinants themselves. And if you picture the CFIR, you can think about how determinants within an inner setting influence determinants within the process domain, or how determinants related to the individuals involved might be affected by the outer setting. There's a lot of complexity there, and that's why multi-level frameworks are so useful. But at the same time, we saw that people really craved a little bit more nuance, again, particularly around those inner and outer settings. So this is this is, I guess, pretty similar to the way the CFIR visual works that some of you might have seen before. And when we wrote our review, we were really proposing adding this additional domain related to the characteristics of systems. This is different than the outer setting when we conceptualized it, because this was really focused on the environment surrounding organizations, practice settings, health systems. At the time that we did this review, we were really intentional not to mess around with existing CFIR constructs. We didn't want to create confusion in the field by having multiple definitions of the same construct floating around. So we didn't suggest altering any existing definitions. But I want to bring us back around to the CFIR 2.0, which, as you know, came out after the systematic review. And I'm really pleased by a lot of the constructs that were added to it. And I was excited that the CFIR 2.0 cites this paper. It's kind of everyone's dream to have Laura Dan-Schroeder cite you. And so it doesn't add this additional domain, characteristics of systems, but it does add really important constructs that I think helps increase the relevancy of the CFIR across settings. Things like local attitudes, which reflects social cultural norms, local conditions, things like economic, environmental, political, technological conditions, like some of you pointed out in the chat. This originally very broad construct of external policies and incentives, which sometimes very hard to operationalize, was separated into many new constructs, things like financing. Constructs related to external pressure became more nuanced, including constructs related to societal pressure, market pressure. I think these could even be further elaborated upon in a world where, again, colonialism really affects the way that implementation occurs within low and middle income countries. And then within inner setting, constructs related to equity were included. such as human equality centeredness, recipient centeredness, deliverer centeredness. So kind of thinking about equity for whom. We also found that the original CFIR really lacked the flexibility needed to interrogate behavior and behavior change. And this CFIR 2.0 includes constructs from the COMB, the capability, opportunity, and motivation um, model, which is really, really useful. So again, really exciting innovations within CFIR 2.0, which I think align very well with some of the findings that we had from our original systematic review. And yet, I think there also might be more room for improvement as people continue to interrogate the CFIR, the new version of the CFIR in their own work. So, with that, I'm going to talk about a little bit more practical of how we've applied this and what it's looked like and some of the triumphs and heartache. This is just a short example from a project focused on deworming. And I shared this project because it was a large study. It was a multi-country study. So we had the opportunity to look at the way the same question guide performed across very different settings. So just as a bit of background, because many people are not familiar with soil-transmitted helminths, this is a study focused on worms. Soil-transmitted helminths, or STH, they're a group of intestinal parasites. They mostly live in areas with warm, humid soil and inadequate sanitation. They are a very common disease. More than 1.5 billion people are infected. It's 24% of the world's population. The current standard of care is to treat preschool and school-age children twice per year, once or twice per year, with deworming drugs, and they're typically delivered at schools, school-based delivery of a drug called albendazole. And this is because children are most at risk of experiencing morbidities related to STH. Things like cognitive delay, growth stunting, malnutrition, diarrhea. And there's evidence that these infections at a young age can affect lifelong income generating potential and are a major contributor to poverty. But everyone can be infected with soil transmitted helminths. It's just that the standard of care is to treat children. There's a method called mass drug administration that's used for STH, but also other neglected tropical diseases where you give an evidence-based drug, an evidence-based intervention to everyone living in an at-risk area. It's much cheaper to treat everybody than it is to test and treat when you have diseases that are so prevalent in really resource-limited areas. There's evidence that when you do this approach, you treat everybody in an endemic area. For some neglected tropical diseases, it's demonstrated that it's possible to actually interrupt transmission, meaning you're eliminating the disease in a given area. But no one has tested to see if that's possible for soil-transmitted helminths yet. So that's kind of the driving rationale of this study called the DRM3 project. And the DRM3 project was funded by the Bill and Melinda Gates Foundation as kind of the seminal study to see, is it possible to stop transmission of STH using community-wide mass drug administration? And what that means is moving from just treating kids to treating individuals of all ages, door to door with community health workers. This was a hybrid type 1 study. The focus was really on these clinical outcomes. At the same time, we aim to develop sustainable and scalable models of delivering community-wide MDA that could be used to inform programmatic decision making. So in partnership with the national governments, the idea was, how do we do a hybrid study that will help us rapidly translate these findings into national policy? What evidence do these governments prioritize as they think about whether or not they'll update their guidelines? And so that was really the focus of the implementation research work. And I'll talk about that now. So as I mentioned, this project took place in 3 very different settings on purpose in order to see kind of the generalizability of some of the findings. And you can see the main partners listed here in Benin, Malawi, and India. So how we use the CFIR, we engaged in multiple rounds of data collection using the CFIR in DRM3. Here's a snapshot of the question guide repository. So these aren't necessarily the final questions that were used, but this was kind of the repository of questions that were identified during meetings with ministries of health and the implementing leads in each country. And we asked questions at three time points during the study at baseline, midline, and endline. And we used the CFIR really differently at each stage. At baseline, we used it to generate hypotheses to prospectively select implementation strategies to help increase the reach of deworming platforms. So we used the data to help us design sensitization strategies, to identify community champions, and to develop other community engagement activities. We used the CFIR at midline to understand determinants of coverage, penetration, by purposively selecting clusters. This was a cluster randomized trial with highest coverage and lowest coverage, and then collecting qualitative data in each and comparing it to identify drivers of coverage. And then we used it at endline to think about um, what are the determinants of scaling community-wide MDA should the governments choose to in order to develop kind of co-develop these implementation scale plans. So I'm just going to share a little bit about our most recent round of data collection at Study Nline, and kind of paint a little bit more of a vivid picture of how we use this. So after 3 years of twice yearly community-wide mass drug administration, we engage in this qualitative data collection to think about, again, what are these key factors that influence scale up and how do these factors vary by different groups and by country. And we engaged with what some people call a vertical slice of participants, ranging from NTD implementing personnel at multiple level. That's the Neglected Tropical Disease Program, sorry, NTD. NTD implementing personnel, government personnel, WHO country offices. But also, most of the data came from focus group discussions with community members, with health workers, with the kind of community health workers who deliver the medicines. They're called community drug distributors or CDDs. And we, again, kind of purposively sampled the clusters that participated based on experiences with the MDA and coverage, including the clusters with the highest and lowest coverage, because we thought that there might be different determinants of scale up in areas that had more or less kind of like successful implementation, so to speak. And so we followed generally the process that you can see here to guide our data collection and analysis. We translated our questions, obviously, into French and Tamil, and in Malawi, data were collected in both English and in Chinyanja. And this was a really interesting exercise on the translatability of certain CFIR constructs and the way we really think about phrasing things like relative advantage or kind of self-efficacy. And that's would be a really interesting kind of full day workshop to talk about translatability of some implementation science terms generally. But we had a process for dual primary coding, with coding teams based in each site and one individual at the University of Washington. We kind of had a process of round robin sharing transcripts for the dual coding. The CFIR, of course, guided the question guide, but it also guided our deductive code book. But we learned through our baseline and our midline data collection with the CFIR that the CFIR did not meet all of our needs, particularly when we're talking about community level desires and community level behaviors. So a priori, we included constructs from the Cone-B model as well, looking at things like social pressures, opportunities, motivation, et cetera. We also found the CFIR 1.0 pretty inadequate for addressing issues of equity and gender, so we preemptively included constructs for those determinants. One sub-analysis we did, we included almost the entirety of the women's empowerment framework because of preliminary data that helped us understand the importance of having really comprehensive gender equity constructs included in our analysis as well. And then we created matrices and thematic memos to help in our theming. So we engaged around 440 people across 41 interviews and 56 focus groups just during this Nline data collection. Most participants were community members, as you can see in the dark purple. And I'm not going to go into the themes in too much detail, but happy to talk about it in Q&A. I'll just say that we kind of had these like six overarching themes, within them 13 sub-themes. And in italics, after each theme, you can see how we are kind of tracking which CFIR constructs had kind of helped us derive that theme. And so, for example, some of these themes included things like community members prefer community-wide MDA to standard of care school-based delivery. That was really influenced by constructs related to relative advantage, tension for change, knowledge and beliefs, etc. And so I'll just mention a couple for the sake of time. The first one, we found that regardless of who was the target of future community-wide master administration programs, people really preferred CMDA, community-wide MDA over school-based delivery. Um, and so community members had a really strong belief that it was possible to break transmission. And this was driven by the CFIR relative advantage code, as I just showed you. And adults really strongly believed that they were at risk of STH and they required treatment just like children. But the biggest determinant of community preferences to scale community-wide MDA was that community members believe that it allows parents to be more engaged in the treatment of their children. And it was noted that home-based treatment results in higher acceptance of treatment for kids who don't go to school and can't benefit from treatment, but also for kids who do go to school. Parents and children were just more comfortable with children receiving these drugs in the presence of their caregivers. We also had a lot of interesting findings around policymaker and implementers' opinions about scalability and sustainability. Um, and really many of them said that they thought that community-wide MDA should be considered national policy, even if the results from the cluster randomized trial were null and it wasn't feasible to interrupt transmission, largely because they thought it would actually have broad public health impact on other target groups, like women of reproductive age who have adverse outcomes related to STH, like anemia and preterm birth. So this really was helpful for us in using the CFIR to help us understand, again, some of these issues related to relative advantage, but also like design and packaging, perceptions about community preferences, compatibility, etc. And then I'll just mention and then wrap up that there's also a big piece on like the perceptions of the providers, the implementers themselves, and how that influences acceptability amongst community members, and what a strong determinant that was. So to wrap up, we found that there were determinants of high coverage included acceptability, which was driven by preferences for home-based treatment of children and the perceived risk amongst adults. And again, if we had time, I would kind of wax on about the complexity of this causal diagram and the different relationships between the determinants that we found. We found that the decision to scale community-wide MDA is driven not only by the likelihood of interrupting STH transmission, but also beliefs about the potential for CMDA to reach key populations more effectively and equitably than standard of care platforms. And then that most participants noted that community-wide MDA should only be scaled in settings where there's kind of a supportive infrastructure already in place. And this is where kind of some of the characteristics of the innovation domain and the CFIR were really important. So what does it all mean? Here are some takeaways that I continue to grapple with, and I would love to hear your thoughts on in a discussion as well. We know frameworks are important, and we know that the CFIR is a uniquely useful framework for implementation science practitioners across settings. It allows us to identify implementation facilitators and barriers, and as I mentioned earlier, even to go beyond facilitators and barriers and to think about the higher order determinants that create those facilitators and barriers. But we also know that frameworks are inherently value laden, and where we derive theory inherently has our culture embedded within it. And so this requires us to kind of consistently re-examine where frameworks might fall short, to always think about our positionality, to have epistemic reflexivity. There are unique behavioral or sociocultural characteristics of a setting, and one has to layer on sometimes additional frameworks, as I mentioned. We really saw the importance of as I mentioned before, gender equity and how gender equity was a really important determinant in driving participation in deworming programs and ideas about who was most at risk of infection with worms, even if they weren't part of national policies. And so we had to layer on an additional framework, the women's empowerment framework, and other frameworks as we went along. And that was really helpful for us. And again, that's why I'm so excited that the CFIR 2.0 includes this behavioral element within it now as well. But also, theory doesn't necessarily need to be static. And so the unique attributes of low and middle income countries versus high income countries, again, things like collectivist versus individualistic societies, low resource versus higher resource settings, ongoing realities and burdens of neocolonialism, all of these might necessitate expanding theories. And I guess just to wrap up, I want to say something I might have said to some of you before that who has a role in playing in generating knowledge? Who has the knowledge? You do. You have the knowledge, and we all have a role to play in expanding theory, especially voices that are traditionally underrepresented in the process. So, what's important is that if you're thinking about using a framework, and you're thinking, this really is lacking something here, I could layer on an additional framework or I could propose a construct. It's important to do so really thoughtfully and with caution to avoid changing definitions willy-nilly, but rather to think about contributing your evidence and your insights and building consensus and proposing items that you think might be missing. I really kind of encourage all of us to continue thinking thoughtfully about how the frameworks we use do or do not um, kind of appropriately represent the determinants at play within the settings where you work or where you live. So I will pause there. I probably talked too long. Here's my email if you have questions.